Hello, welcome to another Tuesday Tip. I'm Dr. Bill Waggoner. This week, I would like to talk to you about controlling hemorrhage prior to cementing zirconia crowns. When preparing zirconia crowns, you're nearly always going to have bleeding after the preparation is completed. Now, for those of us who have used glass ionomers to cement stainless steel crowns, we've become accustomed to cementing in the presence of blood and really not giving it a lot of thought. However, when we use a resin-modified glass ionomer cement, which are the preferred cement for zirconia crowns, cements like Biocem, then hemorrhage control becomes very important. Why is hemorrhage control so important with resin-modified glass ionomers? Well, probably the most important reason is that bleeding will very likely decrease bond strength to the enamel and dentin, and most assuredly it will decrease bond strength to zirconia if the blood contaminates the zirconia. Number two, bleeding may affect the setting of the resin-modified glass ionomer material. And number three, bleeding could potentially show through underneath the crown, giving it a less aesthetic appearance. So I'm going to tell you a few ways that I've found useful to control bleeding prior to cementing zirconia crowns. I rarely use just one method, rather a combination of two or three. Now, there are four basic categories of methods of hemorrhage control: anesthetic with epinephrine, pressure, time, and local hemostatic agents. The thing that I most likely use in my cases is interpapillary injection of 2% lidocaine with 1 to 100,000 epinephrine. I usually do this prior to beginning my preps, but sometimes I forget, and then I don't do it until after I've prepped all the teeth. I generally administer into the base of the papilla until I see blanching. Then I move to the next papilla. I don't believe lingual injections are necessary, but occasionally I'll give a little at the palatal gingival margin. This usually gives pretty good control of the bleeding, and fairly quickly. A second method to control bleeding is pressure. Just like we often will squeeze a socket after an extraction to compress the socket and apply pressure for hemostasis to the site, I'll often use a dry 2x2 to squeeze and apply pressure to the facial and lingual gingiva as the assistant is filling the crowns with cement. Pressure doesn't give long-lasting hemostasis, but it's often good enough for the period of time just prior to placing the crown. Now, a third method for achieving hemostasis is time. If you're doing a lot of treatment, I recommend prepping and fitting the zirconia crowns at the beginning. Use local anesthetic for hemostasis, and then proceed to do the rest of the work in the mouth. Finally, at the end, come back and cement the zirconia crowns. With the passage of time, the hemorrhage should now be well controlled. Finally, some clinicians like to use local hemostatic agents. This might be Vicostat, which is 20% ferric sulfate, Vicostat Clear, which is 25% aluminum chloride, or Astringent, which is 15.5% ferric sulfate. But if I use anything, it's usually 3% peroxide. It's applied in the sulcus area with a Monoject syringe, and peroxide is a mild hemostatic agent. It doesn't leave a residue like ferric sulfate materials do. Also, there's superoxal. This is a 35% hydrogen peroxide agent, which is a very potent hemostatic agent. But due to its high strength, it should not be left in contact with the tissues for more than 5 to 10 seconds at a time. It's dabbed on with a small cotton pledget and rinsed after just a few seconds. Now, it's going to turn the gingiva a snowy white, but the color returns within 5 to 10 minutes. The last locally applied hemostatic agent that's been suggested is hemostatically impregnated retraction cord. This is not something that I imagine most pediatric dentists have in their office, but it can be used effectively. As I said earlier, I usually use a combination of several of these methods. Now, there's a final note that I'd like to make. It's been my experience that if there's no blood on the clinical crown, retention should be fine. But sometimes as you seat your cement-filled crown, you see blood start to ooze out of the sulcus. In my opinion, the viscous cement is displacing the blood away from the tooth, so I don't believe there's any significant concern if you see that happen as you seat your crowns. It's not ideal, but I don't believe you need to start over because you expressed blood from the sulcus. I know I don't do that. I hope these tips today are helpful. Now, if you have any questions or clinical situations that you would like to hear me address, please send me an email at www.aggoner1@newsmile.com. I want to make these tips as helpful as possible. I'll see you next time, and have a great week.